Welcome to the Academy of Ultrasound. This is Echo233, Week 4 Lecture Notes, Chapter 8, Hypertrophic Cardiomyopathy. I'm John Sheldon, one of the instructors here at the Academy. And as always, we welcome your participation and appreciate you following us. Tonight we're going to be talking again, as I said, about Chapter 8, Hypertrophic Cardiomyopathy. This is Echo233. We're going to be dealing with Essentials of Echocardiography and Cardiac Hemodynamics as our textbook. And on the left-hand side of my screen, you'll see the textbook opened, and on the right-hand side of my screen, you'll see the lecture notes that are available on Moodle open. So let's go ahead and get right into it. We're talking about hypertrophic cardiomyopathy. You're specifically dealing with hypertrophic. What we're measuring in hypertrophic is the ventricular wall. Ventricular wall meaning the lateral wall, the inferior, the apical section, the anterior, the septal wall, basically the outer LV walls. They're considered hypertrophic when end diastolic thickness is greater than 1.5 centimeters. What does that mean? Well, that means at the LV's greatest excursion, remember systole is when the LV squeezes, diastole is when the LV relaxes and fills with blood for the next stroke. At the greatest excursion, when the mitral valve closes, before the aortic valve opens and you begin your isovolumetric contraction time, you have the end diastolic thickness. If it's greater than 1.5, it's considered hypertrophic. There's two types of hypertrophic cardiomyopathy. ASH is a indication or an acronym that you'll hear referred to quite often. That's asymmetric septal hypertrophy. It's one of the most common forms of obstructive hypertrophic cardiomyopathy. It's where your basal septum becomes extremely thickened relative to the rest of the ventricular septum. It's seen on the echo as a bulging of the basal ventricular septum out into the LVOT. The LVOT is your aortic outflow tract. When severe enough, there's generally dynamic LVOT obstruction present. Increased blood flow velocities across the narrowed LVOT can cause mitral anterior leaflet to lift up into the LVOT, referred to as systolic anterior motion, or SAM. We refer to the acronym SAM for systolic anterior motion, and it obstructs the flow out the LVOT and aorta. A late peaking systolic high velocity continuous wave tracing from across the LVOT is the signature of this dynamic outflow obstruction, and we'll show you one of those later. But remember, you have different segments of systole. A late peaking systolic high velocity tracing from across the LVOT is a signature of dynamic outflow obstruction. Anterior mitral valve leaflet is pulled anteriorly. In mid to late systole, mitral valve leaflets will generally become separated, resulting in mitral regurgitation. So you'll also have MR with this problem. If the mitral regurgitation is directed along the atrial septum, it may be impossible to directly measure the peak gradient along the LVOT obstruction. So if your MR is directed along your intraatrial septum, you may or may not be able to get a very good pulse or continuous wave track, continuous wave Doppler signal to give you a peak gradient. We have several different windows. If you remember, you have the 5-chamber, you also have the 3-chamber that you can try to get down that LVOT track. M-mode measures include systolic anterior motion of the mitral valve leaflet actually touching the ventricular septum and early closure of the aortic valve. Another form of obstructive cardiomyopathy, hypertrophic cardiomyopathy, is concentric hypertrophic cardiomyopathy. All the ventricular walls are thickened to the same degree. So you have ASH and you have concentric. Remember, ASH is where your septum is thickened, the rest of the walls are not. Concentric is where all ventricular walls are thickened to the same degree. Chronic hypertension, chronic aortic stenosis, and old age are common causes. This would be referred to as hypertensive or hypertensive heart disease is cardiomyopathy, generally associated with Doppler findings of mid-ventricular obstruction. So we're talking about mid-ventricular obstruction of flow, not LVOT obstruction of flow. Make sure you understand the difference. With ASH and an LVOT obstruction, your mitral annulus, your mitral leaflet lifts and shuts off the LVOT. With this concentric form, you typically have findings of mid-ventricular obstruction. Mid-ventricular obstructions associated with this form are generally not hemodynamically significant, characterized on Doppler by a very late peaking sawtooth-shaped waveform. We call it a dagger-shaped in some cases. Again, we'll talk about the Doppler in a little while. Occasionally, these patients develop a mild to moderate degree of LVOT obstruction at high heart rates. Posterior wall thickening can cause anterior displacement of the mitral annulus. The diastolic filling pattern in this form is prolonged relaxation, which would be what? It's grade 1 diastolic dysfunction. Myocardial fiber disarray prevents the ventricular from relaxing rapidly. So when you're talking about hypertrophic cardiomyopathy, systolic midventricular flow pattern, your midventricular obstruction of systolic blood flow is a common Doppler finding with moderate to severe left ventricular hypertrophy, or LVH. LVH is what we use in the field to designate ventricular hypertrophy. Your LV cavity area decreases during systole. Blood becomes trapped at the apex during the midventricular narrowing. This entrapment causes an increase in the pressure at the apex relative to the basal LV cavity. Blood moves with increasing velocity from the apex to the base and peaks at end systole. Flows across the aortic valve peak early, and the midventricular obstruction peaks late. So you have two flows. You basically have a Doppler signal that shows early aortic flow, and then you have late peaking midventricular flow. Blood flow across a subaortic stenosis due to systolic anterior motion of the mitral valve will generally peak in mid to late systole before the midventricular obstruction. So you'll notice that it says midventricular obstruction peaks late, subaortic stenosis due to the mitral SAM peaks in mid to late. So that's how we're going to try to determine which one of these is the consideration. You have a hypertrophic cardiomyopathy has something called the isovolumic relaxation period. Outward motion of the anterior and apical segments of the LV apex during isovolumic relaxation in patients with LV hypertrophy, or LVH, causes early relaxation of the anterior apical LV and creates an area of low pressure. Blood from the base of the LV rushes forward the apex during the isovolumic relaxation period. Early forward flow can be mistaken for the rapid filling phase of mitral inflow. Let's go over here and take a look at these pages from the book. Mid-systolic flow pattern, as we discussed. You see the low pressure that's in the LV basal septum, and you see the high pressure in the apex. And when you try to take that continuous wave signal, you get this very, very late peaking dagger shape. This signal here, or this particular Doppler here, is what I was referring to with the double signal. This is a Doppler tracing in a patient with LVH. The flow across the aortic valve peaks early, and the midventricular obstruction peaks late. If you had a subaortic stenosis due to SAM, it would generally peak in the middle. This is your isovolumic relaxation period flow. This is the flow here they're referring to. Outward motion of the anterior and apical segments causes a characteristic flow pattern shown above. This middle one is your E. This is the rush of blood being sucked into the heart because of hypertrophic cardiomyopathy and this isovolumic relaxation period flow. So when the heart relaxes, it sucks this little bit of blood in, then you get your E, then you get your A. So don't mistake this tall one for the E. This is referring to the systolic anterior motion. You have your aortic flow. You have your aortic flow, and the late peaking, mid to late peaking, is right up against the aortic flow. So it almost makes it look like you're in an MR jet. But you can tell that this is the aorta, this is the peaking from the subaortic stenosis of the mitral valve. So that's it for this lesson. As always, go to Google, search for images, videos. You can search for any of these topics, and you'll find more than enough information floating around the web to give you additional examples. If you find something that you're not comfortable with, please email it to me at john@academyofultrasound.com. I'll be happy to try to interpret it and give you some feedback on it. Other than that, we look forward to seeing you at the next session, and happy studying. Good night.